लोग लॉगिन करते हैं, मैंने कुछ नहीं चलाना। ये क्या आवाज आ रही है? नींबू क्यों नहीं आ रही कोई आवाज? ओ गॉड,
मैम यू कैन नाउ स्टार्ट मैम। आपका वॉइस आ रहा है, वॉइस क्लियर है।
अभी अगर सारे मोबाइल इसका भी फॉलो करो, इंटरनेट बंद कर देंगे, जब दूसरे बोलेंगे तब यहाँ बंद कर देंगे, ठीक है। और वॉइस का वो वॉइस बंद कर दो, नहीं ये कॉल ओवर इंटरनेट, कॉल ओवर इंटरनेट। लेकिन सामने तो कोई दिख ही नहीं रहा है, कोई भी नहीं, कोई भी नहीं। ये स्क्रीन दिख रही है वहाँ पर, स्क्रीन दिख रही है। स्टार्ट कर दूं सर?
यस मैम, योर स्क्रीन इज विजिबल।
सामने वाले सुन पा रही हैं, हमें पता ही नहीं है। सामने जो होस्ट है डॉक्टर सतीश, उनसे कैसे कांटेक्ट करेंगे? क्या नहीं दिख रहा आपको? ये दिख रहा है ना प्रेजेंटेशन? ठीक है,
आपके उस पे एक आया ना मैसेज,
अब इससे बढ़ा दे रहा हूं। आपको फोन पे आवाज आ रही है ना? यहाँ तो आ ही जाएगी। फोन पे शेयर हो रहा है। ओके,
यस यस, आपका पिक भी शेयर हो गया।
Good afternoon, everyone. Talking to all of you.
Yes ma'am. Yes ma'am. Yeah.
Hello, my voice is clear? Clear, na?
Yes yes ma'am.
So I will
Your
start.
voice is ma'am clear. Now you can start also.
We will see something about ocular disorders which are associated with glaucoma management. Elevated IOP in glaucoma, it results from increased resistance within the aqueous drainage system, leading to retinal ganglion cell death, compromise of the musculature, certain ischemia of pyramid, and macular damage due to stress. It is more common in blacks. Glaucoma treatment, it can give us to ocular surface diseases. Then we have to treat ocular surface diseases as well as glaucoma. Some of the studies shows that moderate OSD occurs in 20 to 60% of the cases and severe OSD in 40 to 66% of the cases. The prevalence of OSD was significantly more in glaucoma patients, and it is 72.4% in patients. Sharma's test showed 84% patients had decreased tear production and beauty was abnormal in 67.1% of the patients and lissamine green staining in 36.2% of the patients. Structures can be classified as an ocular surface disorder. As we all know, lipid tear film, it has three layers: lipid, aqueous, and mucin layer. Lipid layer, it retards the evaporation of the aqueous, lowers the surface tension of the tear film, and lubricate the eyelids. Aqueous layer, atmospheric oxygen to the avascular corneal epithelium, It has antibacterial function also. It washes the debris and allows the passage of leukocytes after the injury. Mucin layer, it helps in lubrication. It protects the eyeball with slippery coating and converts hydrophobic into hydrophilic surface. Ocular surface diseases, it may be non-dry eye and dry eye disease. Non-dry eye diseases, that is lid related because of meibomian gland dysfunction, anterior blepharitis. Other reasons are allergic conjunctivitis, chronic infective and non-infective keratoconjunctivitis. Dry eye diseases may be aqueous deficient or evaporative dry eye disease. Patient can come with complaints of discomfort, dryness, gritty, scratchy sensation, burning, stinging, tiredness, and visual discomfort. Early studies estimated a prevalence of 44 to 46% of the superficial punctate keratitis in glaucoma. TUT and Shermer values are abnormal in over 60% of the patients treated for glaucoma. Conjunctival hyperemia, chemosis, and periorbital symptoms like lid edema, periorbital erythema, eczema, or itching can occur. So, how to diagnose? With the help of OSD questionnaire, which assesses the dry eye symptoms and the effects it has on vision-related function in past patient's life, the questionnaire has 3 subscales: ocular symptoms, vision-related function, and environmental triggers. Shermer test, it determines whether the eye produces enough tears to keep it moist. This test is used when a person experiences very dry eyes or excessive watering of the eyes. It poses no risk to the subject. A negative result is normal. Ocular surface stain, which demonstrate areas of damage on the ocular surface. Lissamin green stain is used to demonstrate ocular surface changes. TUT is a clinical test used to assess for evaporative dry eye disease. To measure TBUT, fluorescein is filled into the patient's tear film, and the patient is asked not to blink while the tear film is observed under a broad beam of cobalt blue filter on slit lamp. So, OSD, it has very much impact on quality of life. It impairs functional vision, especially reading, writing, and while you complex environments. 60% of the person with any severity of dry eye report a decline in quality of life. Dry eye disease is also significantly associated with anxiety disorders and depression. So quality of life suffers. It interferes with nighttime driving, reading, computer work, and watching. So how ocular surface disorders in patients who are using topical anti-glaucoma drops. The goal should be, we should be like, before that, I want to tell that we should all know what is the basic behind the ocular surface disorders and the topical anti-glaucoma treatment. We all know all anti-glaucoma drops. It contains preservatives. It may be benzyl cholium chloride or purides, which can cause ocular surface disorders. It causes changes in epithelial barrier, which causes exposure of corneal nerve endings that can lead to irritation. It damages the surface, leads to visual discomfort. So we have to select wisely an effective anti-glaucoma treatment which has minimal or no effect on ocular surface. So how should we get this goal, or what are the different modalities are available? It will be covered in next presentation by Dr. Supriya and Dr. Manushri. Thank you.
इंटरनेट चल रहा है
Dr. Supriya.
Should I start my presentation or there will be questionnaires?
Uh, no, madam. We will take questions end of all three stations. Hello. Hello. Supriya ma'am, we will take all the questions at the end of all three sessions. So once we conclude all three sessions, we will take all the questions. Yeah.
Okay.
So now
should
we
I
will
start my presentation?
Yeah. Yeah, sure, ma'am. Yeah.
So yeah, let me try my screen sharing. Okay, wait for a minute. Thank you. Thanks a lot, ma'am. Thanks a lot, everyone, all my seniors. I'm trying to share screen. Yes. It's not supporting. Sorry, just few minutes for screen sharing. Let me help. Thank you.
Hello. नहीं वो अनम्यूट ही है उनको खुद ही करना पड़ेगा हाँ
Yes. So good afternoon to all my seniors. Good afternoon to all my seniors and dear students. So I think I am audible. I think I'm audible. Okay.
Yes. Yes,
So good
madam.
afternoon, everyone. So I'm Dr. Supriya Mushraf, Associate Professor, Index Medical College, and today I'm here to discuss topic of preservatives and eye drops, mostly glaucoma eye drops, the good, the bad, and the ugly. So first of all, we should know why we use preservative in any ophthalmic eye drops. So the reason why using a preservative in our eye drops is a variety of topical ophthalmic preparation over the counter for ocular disease, including glaucoma. So the rationale behind using different types of these preservatives are three. First, inhibit growth of microbial contamination in bottle, prolongs shelf life by preventing biodegradation and maintaining drug potency, and allow for a convenient and safe multi-dose container for patient use. So the history behind how this preservatives in eye drops started is from year 1960, Following the occurrence of some severe eye infections after multi-dose eye drop uses, the use of some preservatives have been imposed. Many studies have shown that shows contamination of multi-dose eye drops. The infection mode is either due to the touching of the dropper, by ambient air, by fingers, by eyelid, by eyelashes during the drip. The various studies have showed that containers containing these drugs get contaminated, which rate is 88.4%. The most common microbial agent which was identified in this contamination was Staphylococcus aureus, which was coagulase negative, and Pseudomonas. Various studies have also showed severe infection with Pseudomonas aeruginosa secondary to the use of such eye drops without preservatives. So this is the history behind why we started using preservatives in various eye drops. So the factors, now this preservatives helps in decontamination of eye drops and increase their shelf life. But side by side, the preservative toxicity also occurs. So to start with the preservative toxicities, we should know there are various types of preservatives, concentration, frequency, and duration of the preservatives, ocular surface disorders associated with the number and concurrent medication of eye drops. So this is the classification. This will help PGs also in their examination, I think, because there is a question also. What are different types of preservatives used in eye drops? So this will help students over there. So first classification is most common quaternary communions, benzoyl chloride, cetrimide, polyquaternium. Second classification is mercury derivatives, which are thiamercerol or thiamercerol, oxidative complexes or soft preservatives, SOC, stabilized oxychlorocomplex or stabilized chloride peroxide, amidins, alcohols, and parabens, which are chlorhexidine, polyethanol, and methyl paraben. So whenever you, I think whenever you see any eye drop, you should see the compound used and preservative used in that eye drops, so you can better remember this various classification of preservatives used. So after this, most common preservative which is used in various types of eye drops and including glaucoma medications is BAC, benzoyl alchloride. Quaternary ammonium compound, which contains cationic surfactant properties. Basically, it is a type of detergent property. It is most commonly used in all medications, 72% of which ranging in concentration from 0.04 to 0.02. So the very less composition is 0.04 to 0.02. So it preserves multi-dose containers from microbial contamination, as I have already told you. And also, its good qualities are that it preserves the drug in the container, and also it enhances the penetration of the drug into the eye. And how it enhances? It separates the epithelium and hence increase the penetration of the drug which is going into the eye. But for a timing, this is a good property. But when you use any drug for long time, this property gets good property gets converted into bad property. Why? Because this epithelial suppression, this characteristic of BAC can cause solubilization of the lipophilic protective layer of the tear film. Hence, because of this, cellular toxicity occurs. अगर कुछ दिनों के लिए drug use हो रहा है, it's okay, but for a long time, this BAC causes cellular toxicity on calciform cells, entailing a reduction in the amount of mucin and an additional reason for the disrupting of tear film. And we all know that glaucoma drugs are not used for time being, for 1 month or 1 week. It is long, we use it for a long time. Because of this only, this preservatives, good properties converts into bad property. So now this is a table showing how concentration of BAC is increasing and how the ocular effects, side effects is increasing. As you can see, this is the minimal concentration of the BAC, which is causing significant reduction of TBUT, that is tear film breakup time. And as this concentration is being increased, you can see superficial cells epithelial erosion, then 90 to 100 then I will not elaborate it, but you can see that as the BAC concentration is increasing, the side effects of this BAC over this ocular surface is increasing, from tear film breakup time to increased corneal wound healing delay, and it will affect all tear film and corneal infiltration and total destruction of anterior segment, that is conjunctiva and cornea. So it affects each and every part, cornea, conjunctiva, mucin cells, everything. So, so this is the side effect of the BAC with respect to its concentration. Now, effect of BAC on cornea and conjunctiva. This in vivo study have shown that chronic exposure of BAC, which is added in timolol, as we all know, timolol is an anti-glaucoma medication and you use BD, led to a significant decrease in corneal epithelial thickness. Now, the effect of BAC on cornea and conjunctiva, again in vivo study have shown that decreased aqueous tear vessel secretion, decreased conjunctival goblet cell, and decreased mucin secretion. So these are the various side effects of BAC on the ocular surface. BAC also induced excess apoptosis and cell death in rabbit eye in tubercular meshwork. Also, studies, in vitro studies in human study have shown BAC induces cell growth arrest and apoptotic cell death after 24 hours at a concentration as low as 0.0001. So you can see, even if the concentration is so less, then also it is causing apoptosis. So IOP lowering medication preserved with BAC led to increased apoptosis in conjunctival epithelial cells also. So this is the same thing. It is affecting each and every part, cornea, conjunctival epithelial, mucin, goblet cells, everything. Now, chronic exposure of BAC is also the single most critical advance in the treatment of dry eye came with the elimination of preservatives. So as we have now seen that BAC, which is the most common preservative used in any medication, including anti-glaucoma medication, which is used chronically. So that's why the need of preservative-free drugs evolved. BAC is largely responsible for the ocular toxicities and inflammation associated with chronic use of many ophthalmic solutions. And certain clinical studies have also showed that BAC is affecting, again, cornea and conjunctiva. It is not only affecting all the cells of the cornea and conjunctiva, but also affecting OSDI score. As you know, what is OSDI score, ocular surface dry score index. All PG should know what is this index. Schummer's test, it is affecting all this, Schummer's, Lissamin green, TBUT, everything. It is 59% symptoms in one eye, 27% reported in severe symptoms. So basically BAC is affecting each and every part of the ocular surface, cornea, conjunctiva, and also affecting tear film, and hence affecting all the tear film tests. This you can see other study, clinical study which is showing effect of BAC. It is affecting OSDI score, Schummer test, affecting Lissamin green staining and tear film breakup time. So, and also not only drug, as we all know, using more surgery. So the proportion of patients more drugs
Well, Dr. Supriya is facing some network issue, so she is trying to connect once again.
So sorry for the interruptions. There was a network issue. So I was about to tell about the ocular hypertension treatment study, which showed that many patients with glaucoma will require multiple medication for adequate control of their IOP. In up to 75% of glaucoma patients, a monotherapy will fail to control IOP satisfactorily after 2 years of therapy. Hence, we have to shift from monotherapy to dual therapy. And again, as I have told, more the drugs we are using, more the patient will be exposed to the preservatives, and more they will be worsening of ocular surface disorder. So, at the end, this is only a tip of iceberg. As we all know, iceberg is more below the sea as above the sea. We can see various ocular surface disorders like chronic conjunctivitis, toxic keratitis, pseudophemphigoid, allergic dry blepharitis in patients who are using anti-glaucoma medication for long time. Also, there can be various subclinical inflammation, cytokine release, goblet cell loss, and fibroblast stimulation also in patients who are not showing symptoms, but they are having all these things. So this is basically iceberg situation. Thank you.
Yeah. Thank you so much, Dr. Supriya, for your talk. In between, I'll request participants, if you are having any questions or queries, you can put your question in the chat box. So once we conclude all three sessions, we will try to take your questions one by one. Now we will move to our third topic, preservative-free formulations as a new standard of care in glaucoma. I would like to request Dr. Manushri to please share her slides.
Mute.
प्रीति मैम का म्यूट कर।
आप तो मतलब अनम्यूट ऑटोमेटिक हो जाओगे ना। हो गया हाँ आपको इसको बंद कर दें। नीचे
Good afternoon, everyone. We have discussed about the significance of ocular surface toxicity, which is common in patients who are on long-term medications like glaucoma patients. Now, what options we have for such patients? We have preservative-free IOP-lowering medications. Now, as we know, the single most critical advancement in the treatment of dry eye came from the elimination of preservatives such as benzalkonium chloride from over-the-counter lubricants. BAK may cause or aggravate dry eye disease through various mechanisms, as which we have seen earlier. The ocular surface diseases after commencement of glaucoma therapy has shown significant worsening in a number of patients. The meibomian gland disease, dry eye disease, eczema, everything is increased in patients who are on glaucoma therapy. Now, these are the common complaints which the patients of dry eye can have, especially those who are on long-term glaucoma therapy. The most common complaints include pain or discomfort during installation, foreign body sensation, stinging or burning sensation, and dry eye sensation. The conjunctival signs which are most commonly reported are hyperemia, conjunctival follicles. We know that follicular conjunctivitis is common with anti-glaucoma drugs, and also there can be superficial punctate keratitis. So these are the common problems which are seen in patients who are on long-term anti-glaucoma medication. So particular attention has to be paid to glaucoma patients with pre-existing ocular surface disease, because in them, even with the commencement of the treatment, the symptoms can worsen. So those who have pre-existing disease and those who do not have a pre-existing disease but have been using these medications for frequently or chronically over months. So particular attention has to be paid in those patients. We should try and avoid preservative containing topical therapies in patients who do not tolerate eye drops with preservatives, and consider the use of formulations without preservatives as a valuable alternative for long-term treatment. Now, the systemic contraindications for these are allergies, then any specific diseases if they are
Ma'am, you will have to unmute yourself. You are muted.
So we discussed that ocular surface inflammation not only increases the chances of dry eye disease, but it also leads to surface inflammation, which can lead to subconjunctival fibrosis that may result into aqueous outflow blockage, leading to trabeculectomy failure. Besides BAK, polyquad has also shown to have effect on corneal epithelial cells, and it shows even stronger inflammatory response than BAK. It causes reduction in conjunctival goblet cell density, thereby decreasing aqueous tear film production. These are the different anti-glaucoma drugs which are available in the market, and different molecules which are contained in drugs and preservatives which are used. So travoprost can, we have an option of preservative-free travoprost with Zytrab. So the harmful effects of preservatives include conjunctival changes, ocular surface changes, discomfort, tear film instability, conjunctival inflammation, and also histological changes with decrease in goblet cell density. So owing to the potential adverse effects of ophthalmic preservatives, there is an increasing need for preservative-free ophthalmic products among the patients. So what are the options for preservative-free drugs? Like we know that there are two types of preservative-free drugs. One is UNIMS. In UNIMS, there is a single dose vial. It contains about 0.4 ml of drug, which the patient opens every time he has to instill the drop. It is only for one single day use. It can be used twice a day, and it has to be discarded the next day. A fresh vial is opened the next day. So these UNIMS do not require a preservative because they are not for long-term use, but they are expensive, and there's a lot of drug wastage because, as we know, that only 50 microliter is a drop, so most of the drug goes waste. So UNIMS is a good option for preservative free, but it is very expensive. Another option for preservative free is the packaging is made as such that is seen in the next slide. The packaging is made in such a way that whenever the bottle is squeezed, a valve opens to drop for delivering the drop, and the valve closes as soon as the drop is delivered. So this tight situation, because of this, there is no black backflow, so the contaminated liquid or air cannot enter in. And also, there is an air compensation pure flow technology to filter the air. Whatever air is entering inside the bottle, it enters through a filter. So that is why there are less chances of contamination. So these, because of the technology of the delivery of drop, preservatives are not required in this. So these are affordable also, and because they can be used just like any other drugs, so the compliance and convenience is also good. These are some studies which suggest that how these multiple drug delivery systems are useful for long-term glaucoma patients. So to summarize, preserved glaucoma medications cause adverse effects on ocular surface and decreases the compliance to medication, which affects the quality of life. Also, there is increased risk of failure of filtration surgeries with increased inflammation and exposure to preservatives. Multi-dose formulation packaged with Novelia preservative-free vials are the way forward in glaucoma management for improved clinical outcomes.
Yeah, thank you so much, Dr. Manushree, for your presentation. I have got a few questions, but before that, I would request today's moderators, Dr. Baisare sir and Dr. Vandana ma'am, please uh, uh, share your thoughts on the topics and the points which were discussed today regarding the commonality of ocular surface disease in glaucoma. Preeti ma'am, are you there? Uh, Dr. Supriya or Dr. Manushri, if you are still with us. Yeah, Dr. Supriya, just one question which actually popped in regarding the commonality of ocular surface disease in glaucoma. So, I mean, in your practice, what is the percentage of patients that you see with glaucoma? They also have the ocular surface disease. Ma'am, yeah, you will have to unmute yourself, Dr. Supriya. Yeah, fine. Hello.
Dr. Sandesh, could you repeat once again the question?
Yeah, my question was, ma'am, in your practice, how common is ocular surface disease in glaucoma patients? Ma'am, your voice is not coming.
You all hear me?
Yeah,
Can
yeah,
you?
ma'am.
Yeah.
Yeah, yeah.
Yeah, I was not using headphone. That's the reason. So yeah, it's about 50 to 75% of the glaucoma patient coming to OPD and using glaucoma medication, suffering from ocular surface disorder.
Mhm.
Yeah.
So, I mean, considering this much prevalence of ocular surface disease in patients with glaucoma, I mean, certainly considering this particular thing, we need to have medications which are preservative free. And nowadays, there are formulations, the packaging systems is like that. For example, in our Zytrav, which is travoprost. So in Zytrav, the technology is like that. We have this Novilla technology or pure technology, what we call it. It works on
Yes.
two principles. It has got a wall and a venting system. So when you
Mhm.
squeeze the bottle, the wall opens and then the drop falls down. So as soon as the drop falls down, the wall gets closed and there is no backflow of air or any contamination inside. And the air, it will allow the filter, it will allow only pure air to pass inside. It doesn't allow any contamination to get inside. So I mean, these kind of formulations and the packaging systems are coming in, and now they are poised to become the new standard of care in glaucoma management. The next question, ma'am, which was asked by one of the participants, that how commonly you prefer formulations which are BAK free, and what should be the management or approach or the diagnostic approach in terms of these patients?
So is this question for me?
Yes, ma'am. I mean, you can also answer. Yes, Dr. Supriya.
Yes. So basically, I think it should be all the anti-glaucoma medication should be preservative free, but this is practically not possible because most of the time, sometimes glaucoma medication itself is not available where the we are practicing. Means prostaglandin analog itself is very rarely available. Sometime in periphery. So practically, we want to use all anti-glaucoma medication which is like back free or at least preservative free or at least back free, but practically it's not possible because sometimes even drug is not available. So what's there? There is no choice, no, sometimes.
True.
So we work in periphery sometimes, and periphery sometimes even anti-glaucoma medication is only not available.
True, ma'am.
Prostaglandin analog is only not available sometimes. We have to use then dual therapy to lower down the IOP in such patients, very poor patients. So I think theoretically we want to use anti-glaucoma medication which is back free or preservative free, but practically it's still a long run to go. I think because patients are very poor and we work in periphery, drugs are not available, and even if the drugs are available, they are already very costly. And if it is back free or preservative free, again it would be very costly. So I think there is a cost effectiveness is there. Cost is still hindrance for this.
Preeti madam, thank you so much, Dr. Supriya, for
Thank you.
explaining these points. Preeti ma'am or Manush ma'am, if you are there with us,
Thank you.
uh, would like to ask you one question, Dr. Preeti. I think Dr. Preeti and Dr. Manushri, they are not with us. Uh, so we will conclude today's session. And thank you so much, all the speakers, Dr. Supriya, Dr. Preeti, and Dr. Manushri ma'am. Thank you so much for sparing your valuable time and discussing about the various aspects of ocular surface disease in glaucoma patients and the need for the preservative formulations as a new standard of care in glaucoma. I also thank Dr. Vandana Tilgotu ma'am and Dr. Vasari sir for your gracious presence uh, for our session. And we would like to have more such interactions with you all in coming days. And also, I mean, not virtually, but once this COVID phase goes over, we would like to have all these kind of interactions in real as well. So thank you so much and have a wonderful day ahead. Thank you.
Thank you once again, Dr. Sahab, and thank you once again for Preeti ma'am, Dr. Bhaisare sir, Dr. Supriya ma'am, Dr. Manushri ma'am, and Vandana Telgote madam. Thank you very much for your giving valuable time for this session, ma'am. And ma'am, this is the starting for this. In future, we will also do the so many others covered with other topics also and other sessions also, ma'am. Thank you, ma'am.